So I'm helping Euroview as an advisor, and please take a look at the booth, but I'm not going to talk about this. I'm going to talk about prostate cancer, which is very close to everybody here. I was in Rome last week and with my friend Pierluigi Bove, who's a pioneer. He started a large group there, and I don't know how he does, but he's the chief of, 5,000 hospitals there. He's got a group of 20-some urologists. He created the Agile group, which is, I don't know exactly, it's a laparoscopic endoscopic group in Italy. And also I had my really good friend Kunal Ra, who is also the chief medical officer for Naver. Naver is like a Google engine search #1. It's used more than Google in Asia. So very important. And he wanted to actually make sure that we knew about artificial intelligence and also robotics. There are more than 50 robotic platforms nowadays. And the question is prostatectomies. Come on guys, more than 20 years talking about robotics, which is great. It's sexy, it's fun, it's like playing games, and it's good for the patient, but we're still trying to find out why we have to use robotics. We know probably to do some suturing, but if you keep arguing with the same arguments for 20 years, you don't know if you have to save the ratios or not save the ratios or whatever. You want to put the stitch here or that or a different type of suture. It's like with my daughters. When they argue and gave me 10,000 reasons why, but you don't get any conclusion, is because, maybe this is not the right thing to do. So laparoscopy, all the minimally invasive procedures, everything we keep having the same problems: urinary incontinence, erectile dysfunction. What do we know about prostate cancer cells? PCA3, all the other very capped cells, all those different and aggressive cancer lines. They are resistant sometimes to chemo, they're resistant to radiation therapy, but are they resistant to thermal treatment? No, they're not. You can heat up greater than 55 degrees Celsius, denature proteins, or you can really decrease the temperature to less than minus 19.6 degrees Celsius. And I'll tell you, you kill the damn cells, okay? So while I was working, slaving my way through the healthcare system, taking care of my patients, I decided I dedicated all my life, treating and trying to serve the ethnic minorities, the refugees that are really flooding our land here. And what we found out is that when I there was an imaging, they talk about 3T MRI. I said, okay, let's try and see what's going on, since the learning curve of the radiologists got improved. So since we started to get the quality system and started to do MRI fusion, we collected, this was a quality improvement project. And we got all compare Caucasians, Asians, minorities, and African Americans and Hispanics. And what it was interesting is that when we saw this group, we found that majority of the African Americans had more Pirates 3 lesions, while Hispanics had Pirates 4 lesion or 5, and the Asians had lower incidence of significant clinically significant lesions. And the Caucasians had high Pirates 4 and 5. Is the Pirate system perfect? No. but I think we're improving. And let me give you some data and some information just to stimulate your brain cells. Okay, so what we found is, of course, our great number of indigent, DFAP, Medicaid, Medicare patients were there. Only few private patients, which is completely different from probably your practice. Since you're here paying the high price of the registration, I'm sorry, but that's what makes the meeting. It's different from my practice, which I treated the underserved. The BMI was similar, and the prostate size, and I'm not gonna go into the details of this paper, but what we found, there are a lot of lesions for the African Americans and other groups. That means it's a multifocal disease. And then not only checking the number of Peyronie's lesions that are clinically significant, we also try to see what was the significance of the type or the grade of the Peyronie's. So the 3, 4, 5s consider more clinically relevant, and that depends on your radiologist to follow the algorithm how to classify Peyronie's lesions. And I think that is something that you have to learn, but also the radiologist should be a little bit more refined, trying to be more accurate about the Peyronie's classification. So, not to bore you too much, but when we found these lesions and we biopsy with the MRI, we found that the clinically significant lesions 3 plus 3, 4, 4 plus 3, and 4 plus 5 in different groups, we define that majority probably was, this is becoming a little bit annoying, sorry, but our groups really define certain clinically relevant, and they had some previous comorbidities like erectile dysfunction, of course, obstructive disease, and so on. So the PSA density also was collected, and this is not the most important thing that I am discussing today. This is the technique we use, not a big deal. Here, what I like to use is to focus on this image there. You can see the needles very well with this MRI fusion, and we use a software. You can see the ice ball. Everybody says, why you use the ice ball? Do you want to be Iceman? That's not the reason. The reason is because you can see the lesion. And not only that, if you see, for example, let me go next. What I'm trying to point out to you guys is that this is the image of the MRI. This is the ultrasound. You can see there is a lesion here, right? You can see that this guy, 59 years old, density PSA, Peyronie's 5. This is actually an artist. I treated his wife for kidney cancer. Actually, it was the AUA live surgery that I did 2014 that was transmitted to Orlando. And you can see this is the lesion that we got. And now we're gonna basically try to target this area. And he didn't have erectile dysfunction, but just treating one side here, he developed that. But with Viagra, he actually is working pretty well. But you can see with the ice ball where the lesion is. And that is the difference with this system and with the ice ball, with the right there. The hyperechoic lesion is the ice. And so the conclusion is that, of course, the majority of, this is the information, African Americans has Peyronie's 3, Hispanics Peyronie's 4 and 5, and the Caucasians high Peyronie's, and the prostate cancer is multifocal. All right, we know all that. What is the big question? The big question is, can you diagnose and treat at the same time? I think so. Why is this prostate cancer different from renal cancer, for example? So can we save time, decrease the cost, anxiety, and all those good things for the patient? Yeah, so as a quality improvement project, we got 5 patients. Actually, the first patient is a general surgeon, and he asked me, can you just, be done? Do the biopsy, treat it, and so on. And we did. And all the parties had Gleason scores that were clinically significant. The big question is, can we do safely? And what is the only complaint that I got from these guys? Well, if you speak Italian, it's fare pipì con un cavallo da corsa. That means I'm peeing like a racehorse and without Lasix. So that was a great thing. So they're not taking tamsulosin anymore and decreasing the cost of healthcare. Is prostate cancer that special when compared to kidney cancer? I don't think so. Let's be diversity, equity, and inclusion responsible. Let's treat prostate cancer like kidney cancer. The advantages are so many, but one thing is missing is how, if somebody want to question, you cannot do that. You gotta have a pathology. So during COVID, I was bored, communicated with a lot of friends in Brazil, and I said, let's do some AI projects. So we did that. For pathology, we got the #1 pathologist in São Paulo, and she helped me to go over many path reports and biopsies. And what we did was an algorithm using AI to see if the artificial intelligence could help us define what lesions were really clinically significant. And voila, we were able to define that, and we published that data, but still needs human involvement because the pathologist has to delineate where the lesions are. So in conclusion, I think all those things that I talked before, you know them. I don't have to repeat that, but I think in the future, what we have to do is get a better system for pathologists so we can get a simultaneous after the biopsy you just send to the pathologist, and while you're preparing the treatment, cryoablation, you can just stick there, and also the algorithm for the pipettes should improve for you to have some safety, some security to put those needles and start treating as soon as you biopsy. So I'd like you to keep that in mind. And with that, I just want to finish. And what I see is in the future, I've been involved with some AI companies. And this is what I see is that in the future, what you can do is use so you can use a special goggle, and you can have the fusion biopsy lesions in your goggle, and you can directly with a good security that you're treating clinically relevant prostate cancer lesions, and make sure that you decrease the cost of the healthcare, decrease the anxiety of the patient, one treatment, and they're gone. Because my patients had at least 25 to 30% no-show rates after the first visit. Thank you very much, and that's it. And again, John, it's in your court now. I did my job. Thank you very much.